Friends, robotics has occupied a major aspect of various urological surgeries today. Robotic surgery becomes an important minimal invasive treatment at this point in time. At the Kokilaben Dhirubhai Ambani Hospital, where we have both the XI and the SI robots, it is important today to come to you and to make you understand that we have reached that height in both reconstructive as well as malignancies in robotic surgery to extremely high levels. To give you a perspective of that, we do robotic radical nephrectomy and a robotic partial nephrectomy for renal cancers or renal masses which are indeterminate. We look forward to robotic radical cystectomy and ileal conduits or neobladders for the cancers in the urinary bladder. For the prostates, we do a robotic radical prostatectomy, which is either done by our bladder drop-down technique or by a Retzius sparing technique, a technique which has started approximately 5 years ago. In the malignancies, we also look forward to doing pelvic lymph node dissection and retroperitoneal lymph node dissections by robotic technique, which is thoroughly a minimally invasive technique that has taken it to a very high level. While we look at penile cancers, we do the veil, which is again the video dissection of the lymph nodes, and that is done completely today by a robotic technique with an approach directly from the thighs. While we're looking at this robotic urology as an important paradigm shift in urology, in minimally invasive surgeries that we do, which before required an open surgery and we used to cut open with those large incisions, I think we have arrived at a point in time where the reconstructive urology takes a large chunk of our operative work. Robotic reconstructive urology starts from robotic assisted pyeloplasty, where a pelviureteric junction is actually cleared by doing a robotic assisted minimally invasive, wonderfully precise kind of a surgery where we do either a flap technique or we do a dismembered technique of the kind called the Anderson-Hines pyeloplasty. Something in an era where you used to do an open job and you used to attach together, I think things have completely changed on that level. When we look at ureteric strictures, which are iatrogenic and something which continues to happen for a long time, we look at doing a robotic uretrostomy, quite a complex work when we look at the endoluminal aspect of the blockage has to be looked at from externally, and therefore all those innovations that we have done at Kokilaben Hospital, where we leave a ureteric catheter, where we look at flushing the ureteric catheter, identifying it externally and treating it, is what we do in finally identifying the gray zones and doing an anastomotic technique of robotic uretrostomy by a spatulated technique, leaving a 6 French catheter. When you go down the ureter, we look at robotic ureteric reimplantation or robotic ureteroneocystostomy as a reconstructive approach. While we are reconstructing the ureter, and if there's a ureteric loss on the lower ureter, which could happen in various urogynecological surgeries, both open as well as laparoscopy, we have arrived today to do Bowery flaps by a robotic technique. That means we use the urinary bladder part of it as a tubularized structure that replaces the lower ureter. The lower ureter has actually got structured around, and a segment of that needs to be replaced by a tubular structure. So that's an important innovation when we look at ureters, where we would do a segmental ureterectomy for a ureteric cancer, where we'll do a robotic ureterostomy for a ureteric stricture, which is more of iatrogenic or inflammatory, or a stone related situation where the stone has been there for a long time and caused fibrosis in the ureter. And when we looked at the ureteric reimplantations, that's a great innovation which helps us completely minimally invasive to reach there. And finally, the Bowery flap, which replaces a segment of the ureter as required. When we look at other robotic assisted reconstructions, we look at robotic assisted vesicovaginal fistula repair. A repair which we used to require an open surgery, go through those planes and adhesions. Now today, reaching the pelvis with the robotic arms, where the ergonomics helps us to reach that location, identify the fistula, separate the uterus or the vagina from the bladder, and then be able to repair them and interpose tissue, which from the abdomen could be the omentum that is interposed after the wonderful repair on both sides and keeping them together, thus assisting healing and keeping the margins quite safe, has been approached very wonderfully by colleagues and by ourselves in a robotic assisted technique. So robotic vesicovaginal fistula, both for primary as well as for redo surgeries, is a very important reconstruction that we do. We also look at repairing recto-urethral fistula and recto-vaginal fistula with other complexities by directly internal route, where able to reach all the way deep in the pelvis and therefore bring about interpositions flap. Something in an open surgery where we use a gracilis flap from below. We could use the omentum and the peritoneal flaps from above and look at rectourethral and rectovaginal fistula if they are in that domain from where we can approach it from below, in cases where the access to the perineum could be very difficult from below. So I look at robotic pyeloplasty, robotic assisted ureterostomy, robotic assisted Bowery flap, robotic assisted ureteroneocystostomy, robotic assisted vesicovaginal fistula, and rectourethral and rectovaginal fistula. We're talking about those reconstructions where we repair tissues around. Friends, don't forget we also live in the era of tuberculosis, and tuberculosis takes care of a huge amount of distress to kidneys and the urinary tract by being a genitourinary tuberculosis. The bladders can actually be completely lost, and these could be small, thick-walled bladders which are completely inflamed and infected by tubercle bacilli and something which is called as a thimble bladder. A small capacity bladder, a bladder which cannot expand to its total capacity, is something which can be handled completely by robotic assisted augmentation cystoplasty, where we can augment the bladder capacity by using an ileal or using a sigmoid segment. In cases of interstitial cystitis bladder pain syndrome, where we reach an end stage bladder, a bladder which has completely lost its function, which is completely pan-inflamed, where the walls are completely destroyed, and this bladder is unfortunately good for nothing, which we call as end-stage urinary bladder. We reach a location where we are capable of now changing the entire bladder and giving about substitution cystoplasty. That means we substitute the entire bladder now except the trigone or except the bladder neck, and reimplant both the ureters and take it out to such levels around. So patients of this kind of a situation where the bladder has become an end-stage bladder, a thimble bladder, in diseases like tuberculosis, in diseases like interstitial cystitis bladder pain syndrome, we could create a neobladder out of it. A neobladder is also a requirement after a radical cystectomy, where we do an ablative part of the surgery and then a reconstructive part of the surgery. That we evolved from an open surgery to minimally invasive surgery. Today in 2021, we live in an era of wonderfully evolved minimally invasive robotic assisted surgeries around. On one way, we do an ablative surgery for various cancers, which I did talk about, which are the kidney tumors, which are the ureteric tumors, which are bladder tumors, which are prostatic tumors, and which are also RPLND for massive lymph node dissection that we used to do with a large open surgery, is all done now robotically. So those are ablative components. The reconstructive components, which have become wonderful, which is after ablation, could be in radical prostatectomy, we do a vesico-urethral anastomosis. In a case of a situation where we had done a radical cystectomy, we bring about a repair where we will do an intracorporeal or an extracorporeal ileal conduit or a neobladder in such patients around. We at Kokilabhen Dhirubhai Ambani Hospital do gender reassignment surgery as a niche area on reconstruction, where vaginoplasty has been taken over now as a sigmoid vaginoplasty. The sigmoid vaginoplasty essentially has been a redo kind of a situation and not a primary surgery in generations before this. But now patients do come and demand a lubricated kind of a vagina, which can be done best by a sigmoid segment on an ileal segment. We at Kokilabhen Hospital did perform world's first robotic assisted sigmoid vaginoplasty in a gender reassignment surgery as a situation where we created the labia and the external features feminine completely from a male to female surgery, but internally the vagina, which was approximately 6 to 7 inches, was created by an isolated segment of sigmoid that was brought in and fixed in a proper axis and created completely robotically with an intracorporeal anastomosis of the colon. We have taken the subject to the next level, where in cases of internal ambiguous genitalia or in cases of absence of vagina, which is a situation of vaginal atresia and a situation where the vagina is completely absent along with uterus, called the MRKH syndrome. MRKH syndrome is where a woman grows well because her ovaries are functioning very well, but she is absent out of uterus and vagina. So she never has a menstrual period, number one. Vaginal atresia is one where the vagina is absent but the uterus and the ovaries are present, and when she starts menstruating at her menarche, you find she has got abdominal discomfort and pain and a lower abdominal mass collected out of the menstrual blood. That's where we need to probably repair that aspect around and create a new vagina. So creation of a new vagina, apart from gender reassignment surgery that we do by a sigmoid segment on an ileal segment, we replicate that in normal young women or girls who actually have absence of vagina. And this can be done done in two such cases. One is a vaginal atresia, where we need to interpose a vaginal segment from the sigmoid or from the ileum, look at one segment creating, or the one end creating the introitus or the vaginal opening. The other end is anastomose to this ballooned cervix, which has been effaced with blood clot collecting there. The other one could be an MRK syndrome, where there is no uterus, where we would create only a long vagina that, again, with a proper axis and a proper fixation of the vagina at the top end at the sacral promontory. You have got this woman now who's bereft of possible capability as a woman, now has a vagina which is 6 to 8 inches long, which need not be dilated, which is actually a tube already, and which is functional. So these kind of cases have been done by us at Kokilaben Dhirubhai Ambani Hospital, and at Department of Urology. I've been involved in both the cancer surgeries and in the surgeries of reconstruction, which we were doing in the past in the open era. We have come to a point in time where the XI and the SI have both been of assistance. A teamwork that we have taken forward to such high levels in robotic work is something which is an awareness to all of you, because robotic surgery is here to stay. Both for reconstructions and for ablative surgery, we have arrived at a point in time where we are capable enough to help patients reach their goal by able to treat them and cure them as a result of a minimally invasive surgery. Thank you so much.